Dr. Aditi Mehta.
Good morning, everyone. I am a ratified member of AIOS, and I'm here to present my study comparing intralesional and oral propranolol for treating periorbital and eyelid capillary hemangiomas. I have no financial disclosures. Capillary hemangiomas are one of the most common infantile tumors, with 80% being in the head and neck region. Oral propranolol is the FDA-approved first-line treatment for these lesions. However, there's limited literature comparing the role of intralesional propranolol in periocular lesions. We designed this study as a prospective randomized interventional control trial with prospective CTRI registration and ethics clearance. The place of study was Dr. Rajendra Prasad Center for Ophthalmic Sciences. The inclusion criteria was treatment-naive cases of infantile hemangioma less than 7 years of age, having no intracorneal extension, and the guardians of whom were consenting. We recruited 20 patients. At baseline, history and clinical examination was done, with special importance to location of lesion, surface area, color, and elevation. Baseline investigations included keratometry, ultrasonography, and contrast-enhanced MRI to rule out any intracorneal extension, as well as a pediatric cardiology clearance before commencing treatment. The patients were divided into two groups. Group 1, that is case 1 to 10, received oral propranolol at a dose of 3 mg per kg per day for 6 months. Group 2, that is intralesional propranolol, received an injection of intralesional propranolol hydrochloride of concentration 1 mg per ml with a dose calculated according to the longest linear dimension of the lesion. The injection was repeated at day 0, 6 weeks, and 12 weeks. Continued follow-up was maintained, and the final evaluation was done at 6 months. The primary outcome parameter was percentage reduction in surface area, which was further categorized into a scale, with excellent reduction being more than 90%. The secondary outcome parameters included regression in color and change in elevation. Along with this, we also monitored our patients for side effects, both systemic as well as local. At baseline, the lesions were characterized into 4 major types. Majority of the lesions were deep and extensive. Another 50% was skin surface and localized. 2 lesions were skin surface extensive, as well as 5 lesions were conjunctival surface and localized, as depicted by the representative images. At baseline, we evaluated the lesions using a digital caliper to calculate the longest linear dimension. Using this dimension as the length and the dimension perpendicular to this as the width, we calculated the surface area of the lesion. In addition, we characterized the lesions on the color and elevation on a subjective scale. Representative images for the same are given here. Coming to the baseline, both groups were comparable at baseline. The first group, that is oral propranolol, at the end of 6 months, there was a greater than 80% reduction in our patients in this group, which was statistically very significant. In addition, there was improvement in the color as well as elevation. However, 3 patients depicted side effects in the form of lethargy and poor feeding. These were not significant enough to warrant any discontinuation of treatment. Coming to the intralesional group, this group also showed a statistically significant reduction of greater than 67% in our group. There was improvement in color as well as elevation. Even though the trend with the oral propranolol was better, this group was statistically comparable with the intralesional and the oral propranolol, with a p-value of only 0.056. In the intralesional group, there were no side effects. Coming to some of the representative case summaries, the first patient in the oral propranolol group, this patient had a skin surface extensive lesion. After 6 months of treatment, there was greater than 93% reduction in this patient, making it an excellent responding case. Compared to this, one of the cases having a superior-nasal orbital lesion showed only a good response of about 67% reduction. Moving to the intralesional group, this patient had a dark elevated lower lid lesion. After 6 months follow-up, she showed an improvement of greater than 92%, again making it an excellent responding case. In contrast to this, there was another patient with a superior orbital lesion, which was preseptal in location. Despite 3 injections and continued follow-up, the response was poor, about 31% reduction. Seeing the varied response in the intralesional group, we retrospectively compared the 5 patients which were showing a greater than 80% reduction in our group, in the intralesional group, that is group 2A, compared with the other 5 patients showing a poor response in group 2B. We realized that patients having small, localized lesions at baseline responded better with the intralesional treatment. To summarize, this was a randomized controlled trial of 20 patients with a follow-up of 6 months. 10 received oral propranolol, 10 received intralesional. There was statistically significant reduction in both the groups, even though the trend was better with oral. In our study, intralesional propranolol was statistically comparable to oral propranolol. There were no side effects in the intralesional group. In addition, small localized lesions responded better to intralesional propranolol. The strength of our study, it's a long randomized control trial with a 6-month follow-up. Given the rarity of this condition, the sample size still remains small at 20. Also, the need for general anesthesia in the intralesional group is a major limitation in our study. We recommend that intralesional propranolol can be considered a first-line therapy in small surface localized capillary hemangiomas. In addition, it can also be an alternative in patients showing significant systemic side effects with oral propranolol. Thank you.
Thank you, Dr. Aditi. What were the major complications you noted?
So in the oral group, the complications were lethargy and poor feeding. However, these were not significant enough to warrant any discontinuation of treatment.
In local injection?
In the local injection, none of the patients showed any complication in our study.
Did you do color Doppler also?
No, sir, we did not do a color Doppler imaging. We did a contrast-enhanced MRI at baseline and at 6 months for documentation of the lesion, and at baseline to rule out any intraconal extension.
When did you stop the therapy in oral?
So at 6 months.
At 6 months.
Yes. Thank you.
So what would you recommend for large lesions?
Ma'am,
Because in your
yes,
the
ma'am.
case with the large lesion, you didn't get adequate response.
Yes, ma'am.
What is your recommendation for that?
Ma'am, large lesions, first of all, the size, a larger lesion and multiple lesions warrant a systemic evaluation. If there is the presence of systemic lesions or additional lesions, oral propranolol should be the first line therapy because intralesion will only target one lesion, whereas oral will treat all the other lesions. In our study, the maximum dose for the intralesional injection was capped at 1 ml. So any lesion beyond 5 centimeter did not receive a higher amount of dose. So maybe a higher dose can be tried for intralesional propranolol in larger lesions.
Would you recommend combination of oral and intralesional for the larger isolated orbital lesions?
Yes, ma'am, because in addition to the side effect of vasoconstriction and anti-apoptotic nature of propranolol, the injection procedure itself causing blanching and collapse of vessels can have an additional benefit. So a combination of oral and intralesional can be tried.
Is there any article of local propranolol injection?
Is there any?
Is there any other article in literature?
Yes, sir. There are 3 studies comparing intralesional propranolol. 2 of them have been done for non-ocular conditions by the dermatology consultants. And 1 study that is published in Egypt in 2011 compared intralesional steroid with intralesional propranolol. In their study, propranolol had a better result as compared to the steroid.